Safa and Dr. Saad, and welcome to our mega anesthesia learning online. Good evening to everyone attending. It's my pleasure to be here with you tonight, and for the kind welcoming invitation from Dr. Saad. We are currently introducing Dr. Sherif, who holds an associate professor of anesthesia and intensive care and pain management in the Zagazig University, and holds the Aspen European Clinical Nutrition and Metabolism Diploma, as well as a professional diploma in clinical nutrition for physicians from the AUC, and a professional diploma in hospital management from the Sadat Academy for Management Sciences. His talk today will be about clinic management, weaning from mechanical ventilation. Please welcome with me Dr. Sherif. Welcome, Dr. Sherif. The mic is yours.
Thank you, Dr. Hagar, for this nice introduction. I'd like also to thank my dear Prof. Dr. Safa and Dr. Saad for giving me this chance to be part of this great event. Inshallah, in the next few minutes, we will discuss one of our daily practices in ICU, which is weaning from ventilatory support. On daily basis, we ventilate and wean a lot of patients. As all we know, both premature weaning as well as delayed weaning can cause harm and a lot of complications. So we need to standardize and optimize the weaning process of our mechanically ventilated patient. And so our objectives will be what's meant by weaning screen, how to apply spontaneous breathing trial, and how to manage the difficult to wean patient. Our main statement, a team approach. We need a multidisciplinary team. An organized problem-oriented plan are the main and most important to accelerate successful weaning and discontinuation of mechanical ventilation. We have this case, 58 years old male presented to your ICU one day before with acute respiratory failure due to exacerbation of COPD. This patient was ischemic and diabetic. This patient was intubated and ventilatory support was initiated. With the ventilatory setting, SIMP volume targeted mode, respiratory rate 10 breaths per minute, tidal volume 550 ml, pressure support 12 centimeter water, and flow cycling 15%, PEEP 5 centimeter water, FI2 35, and IE ratio 1:2. The patient became tachypnic after stopping sedation according to our ICU protocol. Heart was 110 and blood pressure 120/80, 3 readings of temperature 39, pubic secretions, prolonged expiration, EPG was H7.38, PaO2 66, and BCO2 62, and HCO3 was 34. Now, what's the weaning strategy for this patient? We need to put the weaning strategy. What's meant weaning strategy? What the term weaning refers to? When I say weaning, I go to the weaning from breastfeeding. It's likely similar to the weaning from mechanical ventilation. When we saw weaning from breastfeeding is gradually introducing complementary food alongside breast milk till the food completely replaces the breast milk. It's the same for weaning from mechanical ventilation. It's a gradual withdrawal of the ventilatory support, the transition process from total and full ventilatory support to spontaneous breathing. And this process is like very nearly pure an art, and we need to master this art. How do we perfect this art, the art of weaning? Simply, we could say by the presence of weaning protocol. For sure, the presence of weaning protocols improves the efficiency of weaning process. Protocol-directed daily screening of respiratory function and trials of SPT decrease the time required for extubation, the incidence of self-extubation, the incidence of tracheostomy, and for sure the ICU costs. So we need the weaning protocol. How to wean, the approach of weaning. The first step in weaning is the liberation of the patient from the ventilation, that we are sure that the patient is no longer need for ventilatory support. So we need to ask ourselves, is my patient ready to wean, ready to breathe spontaneously? And then we go to the second step, which is ready extubation. So the first step is the readiness for weaning. And the initiating part is the is that there is an evidence that the underlying cause, underlying pathology indicating mechanical ventilation is significantly treated, improved, and resolved, and then to assess for weaning criteria or readiness criteria to wean, and then to perform SPT or spontaneous breathing trial. So the first step, is my patient candidate for weaning? Is my patient ready to wean today? On daily basis, we have to screen our patients are for the criteria of weaning. This criteria include the first one and the most important one, treatment of underlying cause. That there is an evidence that underlying cause significantly improved and resolved. Then assess the pulmonary function with adequate oxygenation and ventilation with the PF ratio more than 200. The patient can initiate inspiratory efforts, LbCO2 within the basal range of the patient for this patient. Then the third step is to assess for hemodynamic stability. We can wean patients, sure, we need the patient to be hemodynamically stable with no or minimal vasopressor dose. We can wean patient on minimal vasopressor dose. Then to assess for the patient is not feverish, no need for heavy sedation. When this criteria is absent, so my patient is not candidate for weaning. Not candidate, so I will continue with the ventilatory support and assess the patient for the cause, why my patient is not ready. We should assess for the possible causes and manage to make the patient ready in the second trial. If this criteria is present, so my patient is ready to wean and can weaning, you have to prepare your patient for weaning with first a spontaneous awakening trial, stop sedation at 6 a.m. or according to your ICU protocol. Explain what will happen to the patient with head up position. And then we need to assess for readiness or the predictor of successful weaning. If I go to wean, how much I will success with the weaning of this patient with the rupture breathing index, with it, which is a predictor of successful weaning. To calculate rupture breathing index, you have to do it on an assisted with patient unassisted breathing, putting the patient on PSV ventilation with the low pressure support from 5 to 8 centimeter water and beep from 0 to 5 centimeter water. If I do unchanged for 1 minute, and then to calculate rupture breathing index by dividing the respiratory rate over the exhaled tidal volume in liters. If it's less than 100, so the prediction of successful weaning is good. You can perform now SPT or spontaneous breathing trial, which is a continuation of unassisted breathing for 30 minutes up to 2 hours, during which you have to assess your patient for the tolerance of SPT. Is my patient tolerating SPT? You have to assess for the signs of tolerance. You have to assess the patient, the monitor, the ventilator, and the arterial blood gases. The patient for the pattern of breathing. If there is any accessory muscles working, the patient's not sweaty, no disturbance of conscious level or agitation. Then the monitor, the hemodynamics, blood pressure and heart rate within 20% of the baseline, SpO2 more than 90, and the ventilator respiratory rate is less than 35, exhaled tidal volume is adequate, and then the EPG within the accepted range for this patient. If the patient tolerates this simple weaning, you have success on weaning, and this is the simple weaning after the first trial, and should you now consider the extubation and this assess for extubation. Or if the rupture breathing index is more than 100, or the patient intolerant to SPT, so this patient is not candidate for weaning, rest the patient on controlled ventilation on the previous setting, assess for the cause, assess what are the causes to treat and retry after 24 hours. And you may consider non-invasive ventilation. So we have to define what is the weaning success. Weaning success is the extubation and absence of any ventilatory support for 48 hours after the extubation. And weaning failure could be one of the following: either the patient not tolerating SPT, failed SPT, or the patient re-intubated or need any ventilatory support, or even this within 48 hours following extubation. If the patient pass SPT, the next step will to assess the readiness for extubation to consider if the patient candidate for extubation or not. If the patient who fail SPT, we either go to difficult or prolonged weaning, and so we could classify weaning according to the difficulty and the length of weaning process in 3 categories. either simple weaning, the ventilator discontinued after the first SPT. The patient passed the first SPT, so the simple weaning. Difficult to wean patient, the patient need up to 3 SPT trials or up to 7 days to be weaned after the first trial. Or prolonged weaning, the patient need more than 3 trials or more than 7 days to be weaned after the first trial. If this patient fail the first trial, you have to rest the patient, assess for the cause, retry after 24 hours, and you may consider non-invasive. After the third trial or up to 3 trials, patient fail to be weaned after 3 trials, so this is difficult or prolonged weaning. How to manage this patient? You need a multidisciplinary team. For this patient, the cooperation of all the team managing this patient, the primary care physicians, the intensivist, the pulmonologist, the nutritionist, even the psychiatrist. You have to assess the load capacity imbalance. What are the causes that increase the load, and what are the causes that may make the neuromuscular incompetence? It's like checklist, and you have to assess either what are the causes that increase the load. Either there is abdominal distension and ascites, rib fractures, intrinsic beep, edema, even the patient is taking excess calories or overfed. There is a presence of obstructive sleep apnea or other causes that make this muscular incompetence, causes that decrease respiratory drive, that like hypothyroidism, even brainstem lesion, causes that decrease neuromuscular transmission. The most commonly used antibiotics like this aminoglycosides, neuromuscular blockers. There is a new Guillain-Barré or Myasthenia gravis, or even that there is a muscle weakness due to electrolyte imbalance, malnutrition, hyperfusion, critical illness myopathy, critical illness polyneuropathy. So you have to assess all this checklists, prolonged weaning or difficult to wean patient. Consider also the psychological factors. In some patients, the patient feels that his life is in the ventilator, he is dependent to the ventilator, he can't get rid of his ventilator. So you have to assess and explain to the patient and consider the participation of psychiatrists on the team. You may consider to wean on what we call a slow pressure support weaning. Patient may need for tracheostomy tube. This sheet is an example for the daily weaning trial. The first step, as we said, is to assess the readiness criteria. If the patient is ready and can weaning, you have to go to the second step, prepare your patient for weaning. Explain to him head-up position, spontaneous awakening trial. Be sure that your patient is calm and cooperative with RASS score from 0 to -1. Then conduct SPT for 1 minute to calculate rapid breathing index. If it's less than 100, you may continue with SPT for up to 2 hours, during which you have to monitor and assess the signs of intolerance. If patient passes the simple weaning, and you have to assess for extubation. Let's go to our scenario again. Remember, my patient was 58, male patient with acute exacerbation COPD, ischemic diabetic, ventilatory support initiated with this setting. After stopping sedation, the patient was tachypneic, tachycardic, blood pressure 120/80, feverish 39, sebaceous secretion, prolonged expiration with this EBG. As we said, what is the weaning strategy? The first step in the weaning strategy, is this patient candidate for weaning? The answer for sure is no. This patient is not candidate for weaning. As the underlying cause is not treated, it's not completely resolved. There is sebaceous secretion, the patient is feverish, tachypneic, on-stomach sedation, prolonged expiration. All these say that there is still pathology we need to treat. So how to prepare, how to manage this patient for weaning? To make this patient candidate for weaning, you have to treat the underlying cause, control the infection, oppose the intrinsic beep, to adjust your ventilator setting to avoid more complications, and the last step to assess for readiness for weaning and explain for the patient. On the third day, daily screening for weaning reveals that the patient is candidate for weaning. Now, my patient, after three trials, the patient is candidate for weaning. What's your action? The first action, as we said, is to assess for readiness for weaning, assess predictor of successful weaning with rapid breathing index, If it's less than 100, I'll conduct SPT for up to 2 hours and observe and monitor for signs of intolerance. What are the methods of weaning? You know, what are the methods? When I go to weaning, how to wean? As we said, patients ready to wean, predictor of successful weaning, gravitational breathing index. Then we go to SPT. How to perform SPT? What is the method of SPT? We have a lot of methods. The most commonly used is PSV or pressure support ventilation, which we consider the most superior to other methods. Continue with low level of pressure support from 5 to 8 centimeter water, and with beep, low level of beep from 0 to 5 centimeter water, and then you monitor. In difficult to wean patient, you may consider slow pressure support weaning with gradual reduction of pressure support to reach low level from 5 to 8 centimeter water, and then the successful. Other methods include TBs, removal of the ventilator, supplement oxygen with TBs trial, and monitor your patient. Either then another method is going with the SIMP. We may wean on SIMP by gradual reduction of fixed rate till you reach that the patient is nearly breathing all breaths spontaneously. And another method is to extubate and go with weaning in progress with non-invasive ventilation. And the most commonly patients benefit from this method is the COPD patients may benefit from non-invasive after extubation. If the patient passes this SPT, the next step is to assess for extubation, or the second component of weaning process is the extubation. We need to ask ourselves, is my patient candidate for extubation? What are the criteria needed to make the patient candidate for extubation? You have to assess your patient. Is my patient can protect the airway with good conscious level and Glasgow scale more than 10, intubated 8 and extubated 10. To assess the cough power, is it adequate cough power with good cough power? And the secretions, chest secretions, scanty secretions, or there is cubious secretion. If the patient cough power is weak, Glasgow scale is less than 8, suctioning, and there is cubious secretion, suctioning frequency every more than 2 hours, less than 2 hours. So this patient is not candidate for extubation. You have to delay extubation. If the cough power is good, Glasgow scale more than 10, scanty secretions, this patient is candidate for extubation. The next step is to ask yourself, is my patient is high risk for post-extubation stridor? This patient, those patients who are at high risk for post-extubation stridor include those patients with airway trauma, traumatic intubation, prolonged intubation more than 7 days, intubation of oversized tube, patient with frequent self-extubation and re-intubation. All these patients are at high risk for post-extubation stridor. If not one of these patients, I go to extubation. To extubate easily, you have to put the patient in upright position, suctioning of the oral cavity and endotracheal tube. Ask the patient to take deep breath, and during exhalation, you have to deflate the cuff and remove the tube in single smooth motion. Then you have to follow your patient, supplement with humidified oxygen, monitor for any signs of stridor, monitor the SpO2. Early aggressive management should be considered to prevent re-intubation. You may consider non-invasive, as we said, but it's not routinely recommended to routinely use non-invasive after extubation to prevent re-intubation again. So again, if my patient, I ask myself, if my patient candidate for extubation with good cough power or Glasgow scale more than 10 and scant secretions, if not, delay. If the patient candidate, determine if my patient is one of the high risk groups. If no, extubate. If yes, you have to test. If I extubate now, does my patient will go to post-extubation stridor or not? I have to test with the cuff leak test. The cuff leak test is to be performed to assess if there is any airway edema around the endotracheal tube and the patient high risk to go with post-extubation stridor. It should be done while the patient on the ventilator on a control mode, assist control, volume control mode, and the leak. And the leak will be the difference between the inspired tidal volume and the average of the three exhaled tidal volumes. If the leak is more than 110, this positive cuff leak test. If the leak is more than 110, this means that there is no airway edema and you can extubate your patient safely. If it's less than 110, so there is high risk of post-extubation stridor, delay extubation, extubation unlikely successful, and you have to manage and administer antiedematous, which is steroids. Steroids decrease extubation stridor and re-intubation in high-risk patients. Should be administered 6 hours prior to extubation. Dexamethasone 4E intravenous every 6 hours for 48 hours, and then reassess your patient with the cuff leak test. If it's positive, you may consider extubation. If it's negative, you need formal airway assessment with ENT consultation. Okay, my take-home message: for premature weaning as well as delayed weaning can cause harm. Weaning protocol reduce days of mechanical ventilation. You should have a weaning protocol in your ICU. Wean means work together, team approach, early identification, early in the day, early in the course of the management. You have to consider weaning as soon as possible. Assessment on daily basis, daily weaning screen. Is my patient ready to wean? And then notify to start the protocol. Thank you.
Thank you, Dr. Sherif.
Your mic is closed, Dr. Hager.
Your mic, Hager. Your mic.
Sorry. Thank you, Dr. Sherif, for this detailed and well-arranged talk. I myself got a lot of informative ideas from it. I kindly ask the attendees to forward any questions or queries to Dr. Sherif in our chat box. Thank you for your time and effort, and this valuable talk, Dr. Sherif.
Thank you.
I don't think there are any questions in the chat box.
Please, Dr. Sherif, I have my own question for you. Please, it's for me. As regard COVID, all the cases we know put on mechanical ventilation failed to be weaned, and some always it was very bad prognosis. Why?
Regarding COVID,
this destructive, related to the destructive
the nature of the disease itself and the resulting ARDS condition with COVID-19 make it one of the most difficult cases in ventilation and even in weaning. Plus the associated comorbidities with COVID make it difficult to wean nearly. As you said, poor prognosis, most critically ill COVID patients are with poor prognosis. Rarely the weaning in these cases very, very difficult.
Yes.
I saw only few cases we could wean.
Based upon your own experience, do you have some cases that weaned or all?
Very few cases, and mostly we go after weaning with non-invasive. We continue after extubation for a period. In one case, I remember 2 weeks on non-invasive, then completely weaned.
Yes.
The pathology of COVID itself make it very difficult.
Destructive pathology. Yes, Dr. Sherif. Thanks for you.